Wonderful. All right. So, everyone, welcome to another episode of Heart Support Connect on behalf of Heart Support Australia, in conjunction with the Solve CHD team at the University of Sydney. This evening, we have a great speaker as our guest, Dr. Joseph Weddell, who is by background a nurse and has done some wonderful things in the research space, primarily within a cardiovascular disease setting. So Joseph is a registered nurse by background, with specialty in intensive care and cardiothoracic surgery. He's got 8 years critical care experience, working as a clinical nurse specialist before he transitioned into cardiovascular disease prevention research. Don't know if that was a smart thing to do, Joseph, but we'll find out. So never a smart thing to go into research, but all good. His work aims to build on the prevalence of mild cognitive impairment during admission for acute coronary syndrome, and the neurocognitive domains that are typically involved. He's also using qualitative methods to determine the issues people experience, so brain fog, and their families encountering receiving cardiovascular disease secondary prevention education. And his research will provide recommendations for change in practice that will empower individuals with cognitive impairment and or poor health literacy to receive optimal and tailored health care following coronary heart disease presentations. This evening, he will be with us going through a presentation called Memory and Thinking Challenges After Heart Disease. And on behalf of Heart Support Australia, Joseph, welcome, and thank you for being our guest speaker for this month. So what I'll do is I'll hand you over to be our host, and you can share your presentation from there.
Thanks, Christian. Let me just share my screen here. Okie dokie. Can you guys see my screen okay?
Wonderful, all there.
Yeah, perfect. All right. Well, thanks for having me along, Christian, and for the introduction. A couple of things just to correct you on there. I'm not quite a doctor yet. Next year is my PhD going in, so I can't wear that title just yet.
Oh, we got ahead of you.
Someone, no, that's okay. That's all good.
All right. As long as you weren't a professor yet, that's all right. So that's all good.
And I have been working in hospitals a little bit longer than 8 years, but anyway, the rest of it was fantastic. Thank you for that summary. Most of my career has basically been in intensive care, looking after people with different heart disease diagnoses, and that's my clinical background. I'm also an associate lecturer and a PhD candidate in my final year. For the rest of you guys tuning in, thank you for joining us. So I'm just going to be running through some of the research that we've done that's looked at memory and thinking challenges after heart disease diagnosis. And just to say before I start, a really big shout out and thank you to all of my collaborators, the institutions that they belong to are at the bottom of this slide. Okay, so I'll just jump into it. I don't want to teach people to suck eggs, to talk to the choir, so to speak. But just as a little bit of background, we all know that you need to make lifestyle changes after you have a heart disease diagnosis, and we all know that what that sort of typically looks like. You've got to take your medication, you need to stop smoking, you need to exercise regularly, eat a healthy diet, manage depressive symptoms. But there's more to managing heart disease than that. Self-management actually requires a little bit more. You have to understand what the medication is that you're taking. You have to be able to access information when you need to and determine whether that information is trustworthy. You need to be able to manage any psychological or identity impacts that you might have from the diagnosis. You need to be able to build the confidence to manage your condition well, and you need to know what your condition is and your symptoms and your body. So there's this learning phase. And then, of course, you need to learn how to relearn sometimes how to navigate relationships with family and friends, with colleagues and co-workers, with healthcare professionals, and also sometimes with peers, with other people that have had a heart disease diagnosis. And a lot of my research actually focuses on the benefit of peer support interaction. And so that's something I think Heart Support Australia does particularly well, and something that I'm going to be talking about a little bit later on today as well. So that's the background. I'm just going to run through essentially what most of us here will know, the typical journey of someone when they come into hospital. So my research is focusing predominantly on acute coronary syndrome. So that's an umbrella term for those that don't know, for any sort of heart attack or unstable angina that comes into hospital. I'm going to try and talk to some other cardiac conditions as well, in terms of the memory and thinking challenges, because there's a lot of overlap. But my research is specifically in the heart attack space. So you come into hospital with a heart attack, and then you have an intervention of some kind. You have a stent or usually surgery, typically. And then moving into this green area down the bottom, that's when you go home. You might have some discharge education before you go or shortly after you go. And you might go to cardiac rehab, although we know that quite a lot of people don't, even though it's really beneficial. And the aim for all of that is to make lifestyle changes that reduces your chance of having a readmission with another cardiac event. So that's how it should work normally. But of course, there are barriers that stop people from learning how to do secondary prevention and how to self-manage their condition. And some of these barriers include psychological issues like anxiety and depression, fear and stress. All of these things, as well as sort of getting in the way of learning, they also sort of contribute to your risk of having another heart attack or another cardiac event. Some people have issues with their identity. They have to relearn the limits of their body. They lack confidence in enacting these new changes. They might feel isolated or lonely if they live by themselves. They might have changes in self-perception. There's some issues that people experience with cognition, and of course that's the main focus of today's talk, so I'll unpack that in a little bit. And there's also sometimes issues with the suitability of the material that we give to people. Is it relevant to me? Is it relevant to my condition, to my demographic, to my culture, to my language? Is it relevant if I don't have excellent health literacy skills? Can I understand it? So these are the barriers that get in the way. So my research really focuses on different support mechanisms that we've got in place to help tailor secondary prevention. And I've got a real interest in how peer experience can do that and peer support can do that. So I'm interested in the way that peer support interventions, digital and in person, how they can help people after they have a heart disease diagnosis. Video stories as well. It's kind of like a passive form of peer support. You're getting people's experiences there, and online resources. And there's a couple of projects that I've got on the right-hand side here that I'll talk about if I have any time. But as I said, as the main focus, we're talking about cognition and issues with memory and thinking after heart disease diagnosis today. So we're going to unpack that a little bit. Now, I use the term brain fog in a lot of my research because that's how people describe this sort of phenomenon that they experience when they're having issues with thinking. It's a very subjective colloquial term. And so, of course, its definition is subjective and it is colloquial. But when we're talking about a specific process that's happening, the medical term is mild cognitive impairment. So for the first study that I'm going to talk about here, I'm going to use those terms interchangeably. But mild cognitive impairment is medical terminology. It's a medical diagnosis. It's subtle and it's gradual in the way that it comes on. It's detectable with testing. And by testing, I mean using a specific type of survey that detects it. And there's more on that in a little bit. And it's potentially transient. And I say potentially because my research doesn't study the reason why people have brain fog or mild cognitive impairment after heart disease. That's a sort of separate research question. But I will go in to a little bit of detail about why we think that is in terms of what the literature says. So I've put a little exclamation mark up here because there's some lengthy and complicated sort of terms and words, but I'm going to explain them as we go through. when I was working in intensive care before I came across to the land of research, I I had a lot of experience taking care of people after they had heart surgery, and people talk a lot about being a bit confused, not confused, a bit foggy and unable to think clearly for the first couple of days after they go on the bypass machine. We call this going on pump. So that's one thing that's well documented in the medical literature. The medications that we give to people in hospital after they've had surgery or during having surgery, and even for having stents and stuff, we give people some sedatives, we give people some strong painkillers, and all of those things can, of course, make you feel a little bit brain foggy. But in other conditions like atrial fibrillation and heart failure, which, as I mentioned earlier, is not the focus of my research, but in those conditions, another mechanism is hypoperfusion. This is where your heart's not working quite as well as it used to, and putting out the same sort of pressure that it used to put out. And so the perfusion to your brain, the blood pressure to your brain, it sort of is a little bit lower than what it's used to, and you can become a little bit brain foggy from that as well. And the other thing that you see in other literature, so I'm not talking about cardiac diseases now, but other literature is mild cognitive impairment being a prodromal symptom, and prodromal means like a warning symptom or an early stage symptom as a precursor to Alzheimer's. So when there's no cardiac condition involved, in other conditions, people have described mild cognitive impairment as a prodromal to Alzheimer's. There's a couple of CT scans here at the bottom. This one on the left is a normal brain, and in the middle, mild cognitive impairment, on the right, Alzheimer's. So there's this progressive change that you can see. But in the conditions that we're talking about today, in heart disease diagnosis, it's very likely not to be that, and probably to be something else instead. So when I first started researching this, and I met my primary supervisor, Professor Robin Gallagher, she said, do you know that people are actually having brain fog as well when they come into hospital with a heart attack? And I was really surprised by that, because I'd worked for a long time in intensive care and not looked after people at the main door. And this is quite subtle as well, so it's not always picked up. And we decided to do a study from that. And one of the mechanisms we thought might have been causing it in that particular study is atherosclerosis, the buildup of plaque. So if you're having a buildup of plaque in your heart, you may well be having the same thing happen in your brain or in the arteries or veins that supply blood to your brain. And then after that as well, we asked people about their experiences of brain fog, which I'm going to cover in a little bit. And these are some of the things that they discussed as potential things that can cause brain fog. Psychological issues, anxiety, depression, and fear obviously make it difficult to think. Medications, and when you think about, strong painkillers like morphine and fentanyl, you think, okay, well, that makes sense. But for me, it was surprising to hear that statins and beta blockers can also sort of or people also attribute to sort of causing brain fog. Tiredness and fatigue, of course, a big player. Changes of lifestyle, especially if you're very fit and active and you rely on that for your cognition, and that has to change for whatever reason after your diagnosis, that can cause it, and a combination of all of those things above. A little disclaimer, as I already mentioned, so my research does not focus on the mechanisms behind why people are having these cognitive symptoms, but I'm interested in whether these cognitive symptoms get in the way of being able to manage your heart disease diagnosis, and whether it's a subjective bother to people. That's the angle that I'm coming at for these things. So the first thing that we did was we did a small study where we looked at people that had come into hospital with a heart attack, acute coronary syndrome, and we wanted to find out what the incidence of brain fog was during hospital admission for heart attack, the parts of thinking that were typically affected, and the parts of thinking is called the neurocognitive domains. And we wanted to determine who is most at risk. And so what we did was we applied 2 cognitive tests to people that were in hospital with a heart attack. One is called the MOCA, and it tests all of these things down the left-hand side of this graph here. and the other one was called the HVLT, and that is testing one specific part of cognition. On the right-hand side here, you can see this is what the sample of people that were in our study, what their sort of mean characteristics were. The average age was 64, 83% were male, 67% were married, just over half had a tertiary education, and just over half were employed. And so looking at this figure here, you can see that the parts that people struggle with the most, or to put it another way, the parts that people scored least highest on were delayed recall, visuospatial executive function, and attention. So these are the issues that people are having with their thinking in this particular sample of people in this study. And so what does that stuff mean? Well, delayed recall is your ability to hear some information verbally, like now, and then recall it in 10 minutes time. So we'll be doing a test at the end. I'm just joking. Executive functioning is your ability to balance lots of different competing cognitive demands and prioritize what's important. It's also your ability to sort of shut out external noise and stuff that isn't so important. And so you can imagine that this is really, really important to sort of have when you're trying to manage your heart condition. Attention, pretty obvious there, but your ability to stay on task and listen and pay attention. And so what we ended up finding was that with one tool, this tool here, this is where we're looking at all of those domains. There was quite a high percentage. With this one below, which was very specific, the different tool, that's because it's only looking at one domain. When we put those two tools together, we found that over half of the people in this study, so 53% people here, screened positive for brain fog during ACS admission. So this is quite a lot. This is 1 in 2 people. So the next thing we did was we tried to figure out what makes people at risk of having this. And so down the left-hand side, there's some different characteristics there, down this characteristics column. And what we did was we looked at the amount in each different group of positive and negative screening. So this column here on the left is all the people that screened positive for brain fog, and on the right, all the people that screened negative for brain fog. And we looked at what the differences were between the groups. On this right-hand side where it says P, if this number is less than 0.05, then it means that it's statistically significant. So the ones that I've highlighted here are the ones that are statistically significant. And this tells us that they're strongly correlated. So age and marital status and health literacy are strongly correlated with whether people screen positive for brain fog. And so the next thing we do is we do this fancy statistical test, and I won't bore you with the details, but it's called a logistic regression. And what it does is we put all of these different variables into this model. We call it a model, and it allows us to predict what the risk of or the likelihood of somebody having a certain outcome. So the outcome here is screening positive for brain fog. And this column here, the OR, this is the odds of screening positive. So what it's saying is that if you are single versus being married or being partnered, you are 3.6 times more likely to screen positive for brain fog during an admission for heart attack. And underneath here with age, what it's saying is with every year of age past 65, you are 11% more likely to screen positive for brain fog during admission for a heart attack. Okay, so those two were the significant ones. All of the rest in this table, they didn't reach significance. So that's the big takeaway from this paper. And this is kind of reflected here. This is a figure that's just showing people screening positive for brain fog, which is orange, and people screening negative, which is blue. So you can see here past 65 years of age, the amount of people that screen positive for brain fog, it really started leaping up. So age is an important factor in whether you're likely to experience brain fog in hospital. So the takeaway points for this particular study was that brain fog appears to be pretty common after heart attack. We detected cognitive impairment or brain fog in 52%, so roughly 1 in 2. And delayed recall, executive function, and attention are the parts of thinking that are most frequently affected. And you are more likely to screen positive for brain fog. It increases, your likelihood increases by 11% with each year of age you have above the age of 65. And it's threefold higher in people that are single. So, so going back to this figure here, you can see how this kind of how these findings could sort of cause a bit of a barrier here and stop people from being able to learn this. But then we began to think about, well, what happens if the information that people are trying to learn isn't actually that relevant to them? So I'm briefly going to talk about this, and then I'm going to come back to cognition. But I think that there's some important stuff for cognition in here. I became really interested in a condition that's called SCAD, spontaneous coronary artery dissection. Has anybody heard of that before? It's yeah, I thought you would have done, Bob. But so SCAD is a sort of what we used to call a rarer type of cause of heart attack, but actually we realized that it accounts for 4% of worldwide heart attack presentations, and that is quite a large amount considering that cardiovascular disease is the leading cause of death worldwide. It's non-atherosclerotic, so these people that are experiencing this, they generally don't have any cardiovascular risk factors, and it primarily affects a much younger population of people. The mean age is 44 to 53. It's predominantly women, 95% of presentations. A lot of them are fit and active, and they don't have any heart disease risk factors, as I mentioned. It's the leading cause of heart attack under 50, and it's generally managed by not doing anything. So people come into hospital and they have a dissection which is causing the heart attack, and if you do a stent or if you do surgery, it actually makes the dissection worse. So people have generally bad outcomes from that, or worse outcomes from that. So what we do is we monitor people very closely for a week, and then we send them home. And what happens is after a month, the dissection heals itself. It fixes itself back up. So they still have a heart attack, but the actual coronary artery itself, it fixes itself. It doesn't need to have an intervention like we would do with atherosclerotic heart disease. And so that causes a bit of a problem because a lot of healthcare professionals haven't heard of this particular condition. A lot of people haven't heard of this condition. And so healthcare professionals that haven't heard of it, they give incorrect advice. They say you've had a heart attack, so you need to stop smoking, you need to eat a healthy diet, you need to make sure you exercise. And quite a lot of these people that have experienced the SCAD, they already do those things. And because it hasn't been quote unquote fixed, when people go home, they feel like they haven't had a physical fix of their problem. And this is obviously a very, very scary and psychologically impactful thing, and they get worried, and there's lots of different psychological impacts from it. And so, unsurprisingly, a lot of people that experience SCAD, who we refer to as SCAD survivors, they turn to the internet after their heart attack. So we started thinking of ourselves, well, is this information appropriate to people that they can access online? What we ended up doing, and I'm not going to go too far off course with this, I'll just bring it back. But what we ended up doing was we looked at all of the websites that were available in the world that we could identify that were for SCAD survivors, and we appraised them for content, for quality, for suitability, for readability, and for interactivity. And we found a list of different search terms that SCAD survivors might use, guided by consumers. And then we searched them and tried to identify all the websites that we possibly could. And we ended up with 50. And then we appraised all of those websites. And what we found was that websites that were led by peers, that were led by survivors, what we called survivor affiliated, they scored the best for all of those quality domains, alongside medically peer-reviewed health information. So these are websites like WebMD that are independent, but they have fact-checking by a physician. So interestingly, some of the content that's covered on these websites, these are some of the contents. This is the entire contents of the position statements on SCAD. That's that's by the American and the European societies of cardiologies, respectfully. And so what we wanted to find out was, do the websites have this information on? At the top, you can see most websites had a description of the condition and its symptoms, and the symptoms are very similar to atherosclerotic heart disease. So not really surprising, but if you'd had a SCAD and you went to a website, you wouldn't really be interested in finding out what it was. You'd probably already know that. The information that they want quite often is this stuff down the bottom here. Ongoing symptoms of chest pain, very, very common after SCAD. Family pregnancy and planning, that's what a lot of people that have experienced SCAD are wanting to find information about. And here, across here on the gray bar, you can see that this information is just not addressed on a lot of these websites. It's just missing. So this is interesting. And you can imagine if you've got brain fog, this is another thing that you have to contend with. Where do I go? My thinking isn't straight. And where do I go for this information online? How can I tell if it's accurate? Interestingly, in terms of things being accurate, statin therapy here, this big red bar, this is where, according to the position statements, the websites have given incorrect advice or sort of differing advice to what the position statements give. So this is basically just another thing to contend with when you're having issues with thinking and memory challenges. The red bars represent websites that we included in this study that were above the reading grade of 8. And in Australia, the recommendations are that information for consumers should be at grade 8 or below in terms of health. And so you can see that all bar 2 websites were far in excess of that. And this again is really difficult if you're having trouble with brain fog and you're trying to stay on task. It's a lot of information that you have to struggle to understand. I'm going to skip over this in the interest of time, but basically what we ended up finding was that there were multiple websites for SCAD survivors to access, but the content and the quality, the suitability and the interactivity was highly variable, but on average poor to acceptable. And almost all of the websites had too high readability grades. So we provided some future direction for people designing these websites. We said, they've got to make sure that there's lots of pictures on there, that there's summary of key information, and that there's various information formats. But the thing I really want to highlight is that the survivor affiliated websites that, that had a lot of peer input, they scored the highest. And those websites that had video stories and experiences on, they were a really good vessel for getting information across. So this is really where I started to become interested in peer support. I just thought to myself, there's so much information in what peers are saying. This is how a lot of this information is being communicated, and it's being communicated in a way that's easy to understand or easier to understand. If you're looking for a great SCAD website, this is what one of the ones that scored the highest, SCAD Research Australia. So anyway, going back to issues with memory and thinking, what we thought we'd try and do, we'd already looked at the cognitive side, we'd already looked at the suitability side. Nobody had looked at cognition in SCAD, and we thought, okay, well, why don't we have a look at that? But we didn't want to do the thing that we did in the first study where we do a load of statistical tests and we do a load of like tests at the patient's bedside. What we wanted to do instead was ask people what their experiences of brain fog were. And so this is for people that have had SCAD, these findings, but I think a lot of them are applicable to lots of different heart conditions. What we did was we did 7 hour-and-a-half long focus groups of roughly about 30 participants. People were eligible to participate if they'd had a heart attack that was caused by a SCAD within the last year. What we ended up finding was this was the sample of people that were included in the study. There was an average age of 52, a little bit older than the typical age of SCAD, but the rest is fairly typical. 90% female, 90% partnered, 90% employed, all but one living with another person. Roughly half had a history of anxiety, a third had a history of depression, and as I mentioned earlier, that's quite common in SCAD. Approximately half were peri or postmenopausal, and just under half had attended cardiac rehab. This, I think, will be quite relevant to a lot of people. 90% were on aspirin, 70% were on a beta blocker, just over half on a statin, and just under half on a ACE inhibitor or an ARB. So the experiences of SCAD were split into four main themes: the experiences, the perceived causes, the impacts, and the coping strategies. So you can see here people talking about the experiences. They say it was memory lapses, impaired judgment, and difficulty concentrating. And these are some of the quotes that people say over these next few slides. I couldn't remember people's names. I literally didn't. It was like living in a fog. I'd be really interested at the end as well to hear if anybody else has had any of these experiences. The perceived causes for brain fog in SCAD, participants in this study put down to medication, particularly beta blockers and statins. They were two names that came up quite a lot when we were collecting this data. Sleep deprivation and tiredness, of course, causing cognitive fatigue and physical fatigue, and menopause and hormonal changes. The SCAD itself, the heart attack itself, or a combination of all of these things. So the impacts were rumination. It's constant rethinking, not able to get off the thought that you're having. Changes in self-perception, especially for sort of people that were in a young mother kind of family role. Disruptions to hobbies and pastimes. You can see this quote in the middle here. This is from an avid jigsaw solver, and they were just completely unable to do a jigsaw. It's their favorite thing to do in the world. Big impact there. And then probably the biggest impact of all is for this group was not being able to go back to work. And this bottom quote here, you can see one of many examples of people really considering early retirement, just because they felt like they couldn't give their employer their best. And this came across quite a lot in this data. And as I mentioned a couple of slides ago, 90% of the people in this study were employed. So this is a big impact. So this is what I think was probably the most important thing in terms of generalizability to other heart diseases. But the coping strategies for brain fog started with small pragmatic things like setting reminders on your phone, and they eventually evolved through time. So that became setting expectations. Hey, listen, I'm not quite on top deck at the moment. I just need you to repeat what you're saying, or just repeat it slowly. And then that became being one's own advocate, especially with challenging if you were getting incorrect information or not satisfactory information from your cardiologist or your GP. Advocation in terms of you can find somebody else, you can have active conversations and discussions with them, making lifestyle adjustments, and then support from peers being an absolutely massive one in here. And one of the interesting things about this study is a lot of people in this study that had a SCAD, they'd never met anybody else with a SCAD. It was the first time that they'd ever met a peer, another person with a SCAD. And some of the stuff that they took away from just being in the study was just phenomenal. It was really great. But brain fog and fatigue do present big challenges to SCAD, and we think probably to coronary heart disease as well, but we haven't done any studies yet in that space. That's on the cards. Coping mechanisms for these issues developed over time, and they can be shared with peers as a really effective way of getting this information around. And clinicians have great potential to assist SCAD survivors with these challenges. We made some recommendations for clinicians, including having discussions with their patients about symptoms and asking questions, and really trying to championing people to put people towards peer support groups and websites with peer experiences on. And when these cognitive challenges and fatigue are enduring and worsening, we recommend following up with a GP and seeking referral to a health psychologist. This is a study. If anybody's interested, there's a QR code that you can access it with, or you can email me and I'll send them across. But I think I'll leave it there because I'm sort of running out of time a little bit, and I've got lots of time for questions then if anybody has any. Thank you.
Wonderful. Thank you, Joseph, and a very informative presentation. I'm sure a lot of people that will access this afterwards will read this, watch this with a lot of interest. I can see a few people on here tonight just nodding their head. I do have a couple questions.
Yeah.
One question is around, so we saw about the mild cognitive impairment being associated with age, especially over 65, 70, if I'm correct.
Yeah.
How much of that, though, is more probably confounded with the fact that that is more of an age-related type of thing,
Yeah.
that has come about because of perhaps the cardiac diagnosis in the first place? I mean, are we able to kind of differentiate between that?
Yeah, absolutely. It's a really good question, Christian. And obviously, I tried to do a bit of an overview, whistle-stop tour of a lot of these different studies for the sake of
Mm,
variability, and of course there wasn't a lot of time to go into details about things like this. But one of the things that we did for that particular study was that we found the what we call the normative data for the population, or whatever the best indication that we have for that. So that's basically we found what is normal for people to score on that particular
mm,
cognitive tool, um, in terms of population data, and then we used that as a we factored that into our statistical analysis.
mm,
So that differentiated between what people would experience just as a result of aging and not having a coronary heart disease diagnosis, and of course of the coronary heart disease diagnosis on top of that. Did that make sense?
yeah, it does. And look, it's an interesting one because, um, almost, I think with a lot of standard type of admission forms these days in hospitals, they're quite complex for
Yeah, yeah,
patients and things. So and a lot of it's left to the nursing staff and triage when they're assessing them pre and post perhaps admission and surgery. So there is part, if I recall, around cognition or memory and things like that. So,
yeah.
I mean, would you say that the current practices are adequate to determine, okay, you've come in and you were at this level, you've now been discharged, there's been a bit of a reduction or something that's a bit significant. It may or may not be associated with it. It may just be a short-term thing. Perhaps we know anesthesia and these type of things can play a part as well, and they can resolve pretty quickly. What's kind of the process around that, you reckon? Is that quite adequate at the moment?
Yeah, I wouldn't say it was. I wouldn't say it was adequate. It's but with a lot of these issues, there's that everything is sort of far from perfect, but different hospitals do different things. There's not a standardized system. Um,
Mm,
when I looked after people in intensive care, they'd come after their heart surgery, so they'd be sedated when they arrived,
yeah,
and
so it's quite acute.
that was the
Can't
lens
tell
I
that.
viewed it
Yeah.
with. Yeah, yeah. But we've done some other work. We've done some other work that I haven't mentioned in this presentation, where we took the mocker, that main tool that we used, and the mocker was developed to screen for mild cognitive impairment. That was its specific purpose. So it's highly sensitive and specific to cognitive impairment.
Mhm.
And what we did was we did some statistical tests on that. We did a receiver operated characteristics on that, and made a abbreviated small what essentially a mini mocker, so it can be applied in less than 5 minutes at the bedside. And
Yep.
that's one of the things that people could think about implementing. But the reality is, as you already mentioned, Christian, there's already a lot of stuff that people have to do, bedside nurses have to do in hospital, and so it's another thing on top of that list. And there's lots of other things that we do standardly, that I think, I'm not sure about what people here think about, on this Zoom, but I think could be done better as well. I mean, we screen quite regularly for anxiety and depression and psychosocial impacts in the hospital. And I think that is far from perfect. And that is something that's done quite ubiquitously across many health services. And
Yep.
I think that from what I recall having a conversation with you, Bob, about this, but this is one of the things that ends up just not being addressed at all until people come to peer support and they start talking about these experiences. So even though we screen for those things already, it still doesn't give us a sort of perfect solution to some of those challenges.
Yeah, and look, it's an interesting one because since coming into this space, look, I was a clinician researcher like yourself, so you typically, I won't get them acutely, but within a week or two after their admission or their discharge or new diagnosis and these type of things, and we had them, I guess I was doing the exercise stuff, so we had them for quite a long period of time. So you can kind of see things as they normalize.
Yeah.
But one thing I've realized since coming in the space around the peer support is, patients and consumers do tend to open up a little bit differently compared to when they are seeing their clinician, or coming into a clinic, or coming into a hospital. And you tend to start to identify that there may be some sort of, I guess, side effects, or something that's come up. And the question is, is it associated with it? Is it not? Is it age related? Is it not?
Yeah.
And I guess it's very easy for, once a procedure's done, once a diagnosis has been done, it's been a few months, someone who's perhaps, 65, 70 years of age, and it's very easy then, I guess, for perhaps a cardiologist or a medical practitioner say, oh, maybe it's an age-related thing, you're a little bit older, but it could actually be associated with the condition itself. And you have, rightfully said, AF is associated with some, we're starting to see some cognitive issues around atrial fibrillation as well now. So that there definitely seems to be an overlap between the heart and, I guess, the brain,
Yeah.
and how the two can actually work together, interact with each other.
Yeah, there's a lot of that is well documented in the literature with the atherosclerotic heart disease and cognition. That's sort of less well explored, but still quite explored. Not as much as AF and as in heart failure. That's well established and pump. We were saying earlier about going on bypass and stuff, but yeah, I mean, but again, I sort of. I don't I in the, when I started doing this research, I didn't want to get bogged down too much in the what it is that's causing these issues. I was interested in, are you having these issues subjectively? And if you are
Mm.
having issues, what is it that helps? Does it bother you? Does it get in the way of being able to manage your heart disease? And if it does get in the way, is there anything that that we can do or we can recommend that might alleviate that burden, type of thing? That's the angle that I was interested in there with that.
Yeah. No, fantastic. Look, I think I've just got a chat here. I've got a question from Grant Walters, one of our volunteers. Is the brain fog for heart conditions the same as what people have experienced with COVID? That's a good question. And we talk
Yeah.
about long COVID and some of the, yeah.
Yeah, so again, I think I think that again, the mechanism behind that would be different, of course. More, I say, of course. I mean, we don't have any idea. I haven't done any of that research, but the subjective description of what people are experiencing, that is brain fog. So you see it a lot. You see it a lot. People use that language, brain fog. That you see that a lot in chemotherapy, in cancer. You see it a lot in heart failure and AF, as we were discussing, and you see it a lot in long COVID and yeah. So that is the same thing. What we're talking about there, that subjective feeling of not being able to concentrate or just not being able to get, something not just being off with your cognition. That is the same thing there that we're talking about.
Yeah, no, cool. Look, I don't think if there's any other questions,
Could I ask?
Bob,
Yeah.
you can ask the question and we'll head off soon.
Good. Look, with our visitors who go into the hospitals and
Yeah.
visit patients, we've had discussions about what the sort of things that we should raise with them.
Yeah.
That, as you said, the clinicians, nursing staff, etc., normally don't get time to do.
Yeah.
But would you suggest explaining the fact that there's a possibility of brain fog is worthwhile? Because I mean, we've had discussions, and Michael, remember this, on a training course that we did about whether the subject of depression should ever get raised.
Yeah.
My opinion is that it should, because they can be prepared for it. So I was wondering what your thoughts were about whether brain fog should also be mentioned, just so that if it happens, people don't think they're losing their marbles.
Yeah, I think it's a really great question, Bob. And I think my take on it is very similar to your take on depression. I think that of course, what you don't want to do is you don't want to say, hey, look, lots of people get depressed and lots of people have brain fog, and sort of make people apprehensive and make people sort of expect something that might not eventuate. But at the same time, I think that it's a good thing to say, hey, look, after sort of be a bit unspecific. Hey, look, after after you've had this massive shock to your life, shock to your system, and when you sort of come out of the hospital and you're coming to terms with this, it's quite normal to feel a little bit down. It's quite normal to feel a bit anxious. It's also kind of quite normal for people not to be able to sort of string their thoughts together and just to keep thinking the same thing over and over again, and sort of feel like they can't really think straight. I think that's a good way to approach it. And I know you do a fantastic job with this anyway, Bob, but I think of course, this is where I would champion the peer support. Come along to our peer support group. We talk about these issues. You can understand that, like, quite a lot of us have gone through the same thing. Some of us haven't, some of us have, but we all come together and we discuss that. I think that's enormously beneficial.
Thank you. Thank you. The only other quick question I've got is, when you were talking about all of this, I'm just interested as to why being single makes such a difference. What?
That's a great question. I like this question, actually. So again, as I mentioned earlier, I didn't have a lot of time to go into detail with each one of the studies and all of their nuances. With this, it's a hypothesis, but I think that the reason why is that if you live with someone and you're married, you have that you have like lots of different benefits that come with that. So, for example, you have a person that you can sort of soundboard with. You have someone that might encourage you to take your medication or exercise. You have someone that might get on board with helping you to make those lifestyle changes, cook healthier meals and that sort of stuff. I think that is where it comes from. I think that it potentially I think that it's a potentially a reduction in the risk factors that might cause it. So in that first study where we looked at people with atherosclerotic heart disease, our thoughts after we'd done that initial study was, I think what's happening here is that atherosclerosis is also probably happening up in some of the blood vessels that are supplying blood to the brain. So that sort of makes sense, kind of thing. But of course, then when we started looking at SCAD, that there's a different pathology going on, and they still are experiencing brain fog as well. So maybe it's different for them. Maybe it's more psychologically driven by anxiety, depression, fear, and clouding their thinking and stuff. But for the atherosclerotic heart disease, our thoughts were that the most likely hypothesis was we thought was because potentially you have that extra support at home, and that encourages you to sort of have that support and make those changes. And it also sort of forces you to have conversations when if you were living by yourself, you wouldn't be having, you'd be discharged home and you'd be living alone potentially, and you wouldn't be talking to people. You wouldn't be having to think about conversations with people. And so that there might have been that sort of element in there too. That's what we thought from that interested finding, because it's quite big increase.
Awesome.
Yeah.
Thank you very much, Joseph. Thanks, Bob, for the questions, and thanks for the opportunity and the interaction this evening. Lots to come out of this, and I think it's even great for our peer support groups or even our hospital patient visitors that we're going into hospital to kind of think about this topic, because there may be some similarities to what they went through as well, when they had their intervention or their hospitalization or their new diagnosis as well. So I think it's another tool to the chest to realize that patients, consumers, may experience these side effects or symptoms after their hospital journey or after their recent diagnosis. And I think it's important to acknowledge that and obviously, you know, have that open discussion around, you know, what exactly it is, and obviously investigate that further with the medical team. So, and thank you for shedding some light on a really important topic tonight. I'm sure that this will be getting a few clicks on our YouTube afterwards when it's uploaded in the next coming days. So on behalf of Heart Support Australia, Joseph, thank you very much. All the best for your PhD and becoming a doctor next year, even though we introduced you as a doctor at the beginning. But hey, take it on the board. It's a great thing to have. And obviously for everyone out there, stay tuned for our next presentation to come sometime soon. So thank you very much, and everyone have a nice night.
Can I just say before you wrap up, if
Yeah.
anybody's interested and they'd like me to send any of the studies over or find any information, please get in contact. My email address is at the top there.
Perfect.
And also, if you're interested in any of the research that we're doing in peer support, please get in contact too. That would be
Wonderful.
great. Yeah.
And thank you very much. And look, and we are partnering with you guys with the peer support stuff as well, so which is fantastic. And we'll look forward to seeing what happens out of that. So on behalf of Heart Support Australia, thank you again, Joseph. Thanks for our partnership with Solve CHD, bringing you a part of this, and we look forward to the next topic sometime soon. So keep in touch with our EDM or our social media, and we'll go from there. Take care.
Thank you. See you guys. Thank you.
Bye.
Thanks a lot.
No worries.